At this point, I am going to hand the floor over to Sari Schumann, who is going to talk about the program a little bit and guide us through the rest of the presentation. Welcome, Sari.
Thanks so much, Steve. Thank you, everyone, for joining us today for the webinar, Innovative Approaches to Reach Underserved Populations Living with Dementia. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi, everyone. I want to thank you so much for taking time out of your day to join us to learn about this very important topic. I also want to thank Dr. Deborah Cherry from Alzheimer's Los Angeles and Dr. Kelly Barton from the University of Missouri for imparting their wisdom on us. We very much appreciate the work that they are doing and are excited to learn more about it. So with that, I'll give it back to you, Sarah, so we can get going.
Great, thank you. So as you heard, today's presenters are Dr. Deborah Cherry, who's the Executive Vice President of Alzheimer's Los Angeles. For 30 years, Alzheimer's Los Angeles has been a leader in the development of award-winning, innovative tools and strategies to support ethnically diverse family caregivers. Some of these programs include El Portal and the Dementia Care Network Model, Savvy Caregiver Express, Plain Language Caregiver Tip Sheets, and IDEA. Dr. Kelly Barton is a gerontologist and Senior Research Associate at the University of Missouri Kansas City Institute for Human Development, a university center for excellence in developmental disabilities. I'm excited to turn the floor over to Dr. Deborah Cherry to start us off with the presentations.
Wonderful. Thank you so much for having me here, and I'm thrilled to be on the webinar presenting on one of our innovative programs for reaching and educating an underserved population as it struggles with family members with dementia. I'll be talking about our telenovela, which is an edutainment approach to dementia education. This telenovela, let me acknowledge Margarita Bermudez and Angela Landis on staff at Alzheimer's LA, who brought their creativity and cultural competency to the table in the development of this telenovela, which we call Lost Memories. A telenovela is a type of limited series that is similar to a soap opera. It is used widely in Latin America, the words meaning tele for television and novella for a novel. And this telenovela follows a particular family through their struggle with a grandmother, an abuela, who has dementia. Why make a telenovela? Well, according to the U.S. Census Bureau, in 2015, Hispanics constituted roughly 17.6% of our national population. They are the nation's leading, largest ethnic minority, and their numbers and percents are growing. In my particular region in Southern California, they are 49% of the population. Yet they are significantly underrepresented as dementia service recipients. We knew that unless outreach strategies were culturally adapted, this population would not be reached and served appropriately. And in the past, we'd tried a number of successful strategies to reach Latinos, including hiring bilingual staff, placing our services into the communities where people live, adjusting the language and literacy level of materials, recruiting community leaders as spokespersons, and creating dementia care networks, which are partnerships with other organizations that are familiar to and regarded as safe by Latino older adults. But now we wanted to try a new approach, and we were moving forward with more visual approaches to dementia education because, in part because in our region there is a very low health literacy rate, roughly around 6th grade. And we also knew that Latinos watch more television and telenovelas than the general population. Around 55 to 62% of Latinos in all age groups watch an average of 2.5 telenovela episodes a week. And about one-third of telenovela viewers had watched an episode this very week. So there's also some evidence suggesting that the population is more likely to act on education or information they receive on television. and may seek health information this way. And sometimes the information we want to communicate to the population is included in existing telenovelas, and this technique, this strategy, has been used by the U.S. Census Bureau and other organizations teaching about health. But there are others who have created freestanding telenovelas. We're not the first. Fixing Paco is one about end-stage renal disease, and Without Shame is one about HIV and AIDS. So we're not the first. We're just doing it with the topic of Alzheimer's and dementia. The rationale for this is that we would create a culturally competent education tool that addresses health disparities in our ability to provide information about Alzheimer's disease and dementia to Latino communities, particularly Mexican Americans in Southern California. Though I do believe, as you'll see, it's relevant to other groups as well. We wanted to engage communities in a conversation about Alzheimer's and related dementias in a non-threatening manner, and we hope to address some of the stigma that exists in many Latino cultures, but in other cultures as well. And this is stigma that can keep people from seeking a diagnosis or support. The miniseries was created about 2 years ago, and it's 4 episodes. Total runtime is 30 minutes for all 4 together. It is created in English and in Spanish, and each version has subtitles. The names of the topics are there on the slide. We start with an episode where grandmother starts showing signs of cognitive impairment. It's called Warning Signs. In episode 2 is the struggle the family had getting her a diagnosis and facing this as a possible disease. Episode 3 deals with the issue of caregiver stress, and episode 4, coming together and reaching out for help. They can be viewed independently, but they are much better viewed in sequence. So without further ado, I'd like you to meet the Ramirez family. I want you to know that the script was based on real-life cases, situations Alzheimer's Los Angeles care counselors handle in their daily work. Again, the storyline, Grandma Gloria is starting to show some signs of forgetfulness, but not everyone at home is ready to accept this reality, and the telenovela will follow them over their overcoming of stigma. Let's show a clip of that telenovela now. This episode's called Happy Birthday. Steve?
Early, Claudia.
It's me, Jackie.
Of course, you are Jackie.
What are you making?
Your mama's favorite mole de olla. She works so hard. It's a surprise.
Oh, that's sweet, Abue.
How was the school, Claudita? Happy birthday, mi Claudita.
But it's not till the end of the month.
But after a full day in that restaurant, you deserve to relax.
Wow. Mole de olla. Thank you, Mama.
Gloria, this is undercooked and oversalted.
Oh, I'll put it back on the stove here.
You've grown so fast, Claudita. 15.
I'll be out late studying with Sergio for the midterms.
By yourselves?
Scott. Sergio's a good guy.
Dessert, anyone?
No. I'm good.
Abue, what are you doing?
I'm going to the market for eggs, but I don't see my kids.
It's midnight.
I have to feed the kids before school. Let me go.
The market is closed.
I have to go.
No, Abue.
Let me go.
No, Abue.
Yes.
Abue.
I have
No,
go.
no.
Let me go.
No, I don't know. Mama, why are you dressed?
I was I go to the market for eggs.
I'm going back to sleep. Good night.
Okay, Mama, what's going on?
I guess you want to get breakfast.
This isn't normal. Jackie, don't start. She was looking for her keys, which were already in her hand, and she was about to open her. She's just getting older. That's what Dad says. It's dark outside, and she can tell it was night. Huh? Something's wrong. You need to do something. The last thing I need to worry about is something else. I will have very sorry. I'm really worried about it. You should be too. It can be tricky to identify early symptoms of Alzheimer's. Memory loss can be related to other health issues. If you are worried about your memory, talk to your doctor. It's better to be safe than sorry. Alzheimer's Greater Los Angeles can help. 1-844-HELP-ALZ. 1-844-435-7259.
So I hope that you all will agree with me that the acting and the script writing were pretty close to what many families do experience as they struggle in the earlier stages with a dementing illness. When we presented the telenovela in our community, we presented it in 3 different formats, and we wanted to take a look at whether the different formats had differing degrees of reach and of impact. So some of our telenovelas were shown in community settings with a facilitator to different groups, and that could be in a church or a senior center, a daycare center. Others were shown by individual social worker care counselors to families with follow-up discussion with those families. And the third type of viewers were viewers of our online release. We released it 1 episode at a time over a period of 4 weeks, much like soap operas are released in the real world. We asked everyone who participated to complete a survey, and we did receive in the first year 760 surveys back. And you can see that while the majority of people who viewed the telenovela, and this is partly because of our marketing and our outreach, but the majority were Latino, about almost 70%, but other ethnic groups viewed it as well and participated in the evaluation. The in-person group, I would note, reached an older demographic, while the highest number of users of the online delivery were younger, aged 45 to 54, as opposed to 65 plus in the face-to-face groups. We found that the largest number of people we were able to reach was through the online approach, and the fewest reach were through care counseling. And in fact, when we evaluated impact, we had to eliminate the care counseling arm because there were so few people who received it through care counseling. Our outcomes showed that we did have an impact about knowledge of the disease and about stigma, and this was slightly higher for the in-person group trainings with a facilitator, but the online groups also reported statistically significant improvements in addressing their understanding about dementia and their embarrassment about the behaviors of someone who has Alzheimer's disease. So it seemed to have an impact on stigma. There were challenges to developing the telenovela. When we developed it, we filmed it in Spanish, we filmed it in English, we didn't do subtitles, and yet many families come to see this as a family where the older generation may be more fluent in Spanish, the younger generation may be more fluent in English, and they would like to see it together, so the subtitles really help with that. We also were challenged in finding fully bilingual actors, especially ones who were willing to work for what we could pay for filming of the telenovela. And we didn't originally plan on developing a facilitator guide, but gratefully with ACL support, a facilitator guide has been developed. We also had challenges in disseminating the telenovela. Many of the sites at which we wanted to show it thought it was a full-length movie and only in Spanish, and they were resistant to giving it a try, had to be educated about its availability in English, its ability to be shown in segments over a period of time with a facilitator. We also had problems capturing survey data, especially for the online presentations. We didn't want to prevent people from viewing them by making them fill out pre-posts, and so some did and some did not. And we found that this didn't work as well for people who called in for care counseling, often because those families were so overwhelmed by a challenging caregiving situation that education wasn't what they wanted in the short run. They wanted help with mostly crises. The lessons we learned were that we believe this is most effective in a group setting and as a guide to initiate a conversation rather than as a standalone video. We think that the facilitator can engage the audience in a dialogue about what's happening rather than just having people passively view the telenovela. And so the facilitator can use probing questions to get the audience involved rather than passive. Remember to, we also want to remind everyone to connect this, to connect people to supportive services. Hopefully you're all seeing the slides as I present them. I'm up to slide 13. I'm providing you with some references in case you'd like to learn a bit more about telenovelas and how they're used in other conditions. I want to acknowledge the support from the Arthur and Roop Foundation, who initially helped us fund the creation of the novella, and from the Administration on Community Living, who helped with evaluating it and creating a facilitator guide. For those of you who are interested in accessing it, it is available both on YouTube and on Alzheimer's Los Angeles' website, alzheimersla.org/videos. And at this time, now I would like to turn the presentation over to my co-presenter, Dr. Kelly Barton.
Thank you, Dr. Cherry, and thank you everyone for joining us today. I have a lot to cover, so I'm going to get right into it. Here's a quick overview of what I will be covering today. I'll first discuss the rationale for this project and give a brief overview of the Reducing Disability in Alzheimer's Disease, or RDAD program. And then I will discuss how we use mobile technology to implement RDAD with 2 different populations. And finally, I'll wrap up with some lessons learned and preliminary outcomes. In our community, like many others, we identified a need for evidence-based programs to support populations that are less often the intended or appropriate audience for programs or interventions. And I'll talk more about the 2 specific populations we included in the current project in a moment. But because of the diverse need of our identified populations, we recognized the need for programs that allowed a flexible approach. And we identified RDAD as a program that could potentially meet the outlined needs, and as a result formed the Kansas City Collaborative for Dementia Capability. We're actually currently in year 4 of the project. Our stated goal was to increase capacity and improve access to person-centered evidence-based support that helps caregivers and persons with Alzheimer's disease and related disorders, or ADRD, as I'll use throughout this presentation. And those with IDD and ADRD to live independently and safely at home. To accomplish this, we adapted RDAD, which is an evidence-based exercise and behavior management program for mobile technology delivery. Just a quick overview of the RDAD program, and then I will walk you through our modifications and implementation. RDAD contains 12 modules that interventionists implement with dyads. Dyads include persons with dementia and their primary caregiver. The 12 modules contain 2 components: behavior management training and an exercise program that focuses on 4 areas of exercise. And we'll take a closer look at these in a minute. And just a few key findings from the original implementation of RDAD. In 2003, Dr. Terry and colleagues demonstrated that RDAD could reduce perceived disability and increase active days among participants. And just to provide some context there, the program was implemented in the 2003 study by master's degree level home health professionals with oversight from physical therapists. Later in 2014, Dr. Menny and colleagues implemented RDAD across Ohio through the Alzheimer's Association chapters and were able to demonstrate that RDAD could reduce caregiver unmet needs. And now moving on to our current project and how we integrated the use of mobile technology into the RDAD curriculum to be able to implement it with our identified populations. Our regional network of partners in Kansas City has been implementing the 12 program modules with dyads containing a primary caregiver and either a person with moderate to moderately severe dementia of any cause. And for our purposes, that was a 5 or 6 on the global deterioration scale. Or dyads that included an individual with IDD with either ADRD, a diagnosis, or they were at risk, meaning over the age of 40 with a Down syndrome diagnosis. And for this population, the caregiver had to identify changes in behavior as a concern. Agency specialists from our partner organizations who had been trained as RDAD interventionists then train caregivers in the behavior management component of the RDAD program. And for our project, agency specialists had to have a bachelor's degree, and they also had to have RDAD interventionist training and dementia training as well. And because our partner agencies identified the exercise component as a limiting factor, as it's kind of beyond the scope and expertise of their social work trained staff, exercise instruction is provided by the University of Kansas Medical Center, exercise specialists through technology and telephone support. And so specifically, the KUMC exercise specialists made simple teaching videos to cover the exercise module content, which we made available in several ways on tablets, on very simple electronic picture frames, and via DVD. And the exercise specialists also provided regular telephone or video conference support and consultation on safe exercise. We focused on very light, simple exercise instruction to accommodate a wide variety of abilities. This was not intended to be a structured fitness routine. Exercise was framed as a pleasurable event or an opportunity to have an activity that the dyad could regularly do together. To participate, dyads could not have any physician-imposed activity restrictions and had to be able to walk across a room with or without an assistive device. And to accommodate the diverse living and care situations of our target populations, dyads could include either formal or informal caregivers, but they had to provide 32 or more hours of in-home care per week to the person for more than 1 year. And lastly, the behavior management component targets changes in behaviors rather than established patterns. This is an important distinction for our IDD population to ensure that we're targeting dementia symptoms rather than disability-related behaviors. So over the next few slides, I've outlined the content contained in the 12 RDAD modules. We don't have enough time today to cover them in detail, but I wanted to provide a more concrete understanding of what the curriculum entails. And importantly, I also want to show how we use technology to implement the exercise component. And I've highlighted these activities in yellow. Of note, interventionists are not required to cover the modules in order, so they have the flexibility to address the most pressing issue or an area of interest for the dyad first. There are 4 instructional exercise videos with a required call to our exercise specialists accompanying the first 4 behavior modules. And exercise modifications are provided in the exercise videos. As you can see here, Module 1 provides baseline information and education. Module 2 introduces the concept of managing expectations as well as the first area of exercise. Dyads are introduced to the strengthening exercise video and connected with the KUMC exercise specialists. Module 3 focuses on using the ABCs strategy to break down and address challenging behaviors. This strategy involves identifying the behavior, gathering information, and looking for patterns of the behavior or antecedents, and recognizing the consequences of behaviors. Interventionists work with caregivers to brainstorm strategies to change antecedents and consequences. And then the balance exercise video is also introduced during Module 3. Module 4 focuses on application of the ABC's strategies to address challenging behaviors and on improving communication within dyads. At this time, both flexibility and endurance exercise videos are introduced. Modules 4 and 5 also introduce tools such as the behavior diary and problem-solving form. And Module 6 provides an opportunity for them to reflect and review on their progress. Modules 7 and 8 focus on the role of pleasant events in addressing challenging behaviors and exploring how past hobbies and activities can be modified to meet changing abilities. A brief section on nutrition is also included here, and dyads continue to use the exercise videos throughout. Module 9 focuses on caregiver stress and coping strategies. This includes expanding the application of the pleasant events curriculum to the caregiver. And then finally, modules 10 through 12 allow for a review of information and skills and include an opportunity to tweak strategies and finally to develop a maintenance plan. I wanted to quickly acknowledge our wonderful partners listed here, particularly Dr. Vidoni at the University of Kansas Alzheimer's Disease Center, who has led this entire effort and all its moving parts, as well as the 8 partner organizations who actually implemented RDAD with the people that they support. I do want to highlight how diverse the role, structure, and function of all of our project partners who implemented the program are, as this will kind of inform some of our lessons learned later on. For example, only the first 3 listed there provide supports and services to the IDD population. And the first one is the only one that solely focuses on the IDD population. And then each also provide very different services. So number 1 there, ETOS, for example, provides service coordination only, while the other providers provide a variety of services. And each also have a very different service structure. So number 5, for example, Shepherd Center is largely a volunteer-based operation. So now I'd like to switch gears a little bit and finish by discussing some lessons learned and preliminary outcomes. Lessons learned were identified through quarterly all-hands meetings, as well as individual staff fidelity checks and interviews with 1 to 2 representatives from each partner organization. Of note, many of the lessons learned are not unique to either population served in our project, but I will note that those that are unique to implementing RDAD with individuals with IDD as I go along. Listed here are a few of the challenges we encountered throughout the project. I alluded to the first one earlier, and that is really the diverse structure, capacity, and population served by our partner organizations. Along those lines, we required interventionists to have a bachelor's degree, ideally in social work, which posed a challenge for our partner organization that is largely volunteer-based, for example. It was also challenging to move from the capacity building of organizations and knowledge acquisition of interventionists to establishing a comfort level in implementing the material and being able to apply it to diverse situations. Establishing clear, concise marketing on what RDAD is and who is eligible to participate has been an ongoing learning opportunity for our group. Having the exercise component and the behavior management component provided by separate entities, introducing a variety of technologies, and the logistics of sustaining this long-term continue to also pose some challenges for us. And we also identified a few challenges that were specific to providers who support the IDD population. The most pervasive barrier was that most had limited dementia capability or knowledge about supporting individuals with IDD and ADRD. Identifying appropriate and eligible formal caregivers to make up a dyad was also a barrier. And lastly, the philosophies or strategies that advocates in our field have worked very hard to make an integral part of IDD supports like teaching new skills or fostering independence, sometimes run a bit counter to strategies to support someone with ADRD. We were able to use some of the feedback gleaned early on from our quarterly all-hands meetings and interventionist fidelity checks to address some of these challenges or barriers along the way. One of our first tasks was to make sure interventionists had enough training and resources to be able to implement the curriculum accurately and consistently. We worked with each partner organization to provide additional RDAD or dementia and IDD training sort of as needed. We also allowed flexibility in the process without altering the curriculum content so that the diverse organizations serving diverse populations could make the program work for them. And lastly, we wanted to make sure that the exercise component was not a deterrent to potential participants. So it was often marketed or introduced as activity instead of exercise and was kept very light and fun throughout. In addition to the challenges, we also had several successes that are not necessarily captured in our outcome measures, but worth noting. Throughout this project, we were able to provide a great deal of outreach and education to professionals as well as to individuals and families. Improved communication at several levels was also a significant theme from our partner interviews. Caregivers and staff learned strategies for interacting with someone with ADRD. Also, implementing the RDAD curriculum. In doing so, interventionists had more frequent face-to-face, more in-depth interaction with the people they support than they normally do in their traditional support role. So they are really able to build a rapport with families. Our partner organizations really saw the value in this approach, and many discussed continuing it more broadly beyond this project. IDD providers received additional training and information on dementia and IDD, and many felt that this was something they greatly needed and were lacking in their current training. And finally, project partners also reported that it was really just a relief to have something tangible and time-limited for people with later stage ADRD and IDD and ADRD. We also identified characteristics that facilitated successful implementation of RDAD at both the organizational and dyad levels. For organizations, those characteristics included providing an array of services instead of just a single service, having previous experience piloting programs, as well as having organizational buy-in at all levels. And really that means where staff and administration see the value of the program and also have a shared vision for success. Project partners felt that the IDD population and their families were really kind of a natural fit for RDAD and were generally pretty easy to recruit because they were often already connected with the formal service system. And in general, partners felt that RDAD was appropriate and useful for those with more advanced ADRD, but perhaps not as beneficial as in early stages. And lastly, they felt like regimented or structured caregivers particularly seemed to be the most receptive to the curriculum. One of the main successes of this project that will continue beyond the life of the grant is the collaborative network of diverse organizations that have developed infrastructure for referrals and for resource sharing. Inroads were also made more broadly with community organizations through our extensive outreach and training efforts. But when I asked our partners about sustainability of RDAD in their organizations beyond the life of the grant, many envisioned using it more like a toolbox. So in other words, they would continue using many of the components of RDAD to enhance the services they already provide, but without additional funding, they wouldn't be able to continue to adhere to the protocol. And the components they listed are on the screen. And sustainability also requires funding. As we know, our partners had kind of varying degrees of optimism that they would be able to adequately fund RDAD moving forward, but two of the solutions that they mentioned were kind of predicated on the fact that RDAD is an evidence-based program. And as such, there may be an opportunity to establish RDAD as a reimbursable service through Medicare or Medicaid, or to apply for local tax levy funds where available. And overall, we are developing an implementation manual that outlines our methods and incorporates some of our key lessons learned and takeaways. Just quickly, a few outcomes, and please note we're still actively implementing RDAD, so these results are very preliminary. One of our biggest successes, as I mentioned earlier, was the extensive reach we've had through our outreach and education in making the region and kind of beyond more dementia capable. To date, we've trained about 500 professionals, most of which provide supports and services to individuals with IDD. We've also screened over 1,100 individuals for eligibility and enrolled 150 dyads. Of those, 88 have successfully completed at least 9 of the 12 modules, but I do want to note only 20 of those 88 dyads included an individual with IDD. Each of our partner organizations collected 3 pre-post measures: caregiver strain, caregiver unmet needs, and neuropsych symptoms. Here you see some preliminary results from all 88 participants who have completed participation in RDAD. And so as you'll see on the far right of the table, there are asterisks next to each of the results. This indicates that all pre-post changes and ratings on each of these measures were statistically significant. So 3 asterisks indicates the highest level of significance, meaning that there is a very low likelihood, less than a 0.1% chance, that these changes were due to chance. 2 asterisks indicates a likelihood of less than 1%. I did do a quick analysis of results from the participants with IDD and ADRD. However, there were fewer meaningful results. Currently, as I said, there are only 20 individuals with IDD and ADRD who have completed participation, so having too few data points is likely a factor in that. Also, 17 of the 20 of those were a part of a dyad that included a formal caregiver, and paid caregivers are likely impacted a bit differently by the program. Interestingly, one of the significant findings was the change in ratings of neuropsych symptom severity. So we saw a decrease in how caregivers rated the severity of neuropsych symptoms like agitation or anxiety. And this is kind of in line with the feedback from staff at our partner agencies that serve the IDD population, who instead of discussing a reduction in stress or burden, talked about feeling less frustrated because they now know or now better understand dementia symptomology and progression and have strategies to address some of the challenging dementia-related behaviors. And we hope to have more individuals with IDD and ADRD in RDAD by the end of this project year so we can better understand the impact on this population and their caregivers. Preliminary results also showed that a significant increase in activity for persons with ADRD as measured by their caregiver reports of minutes walked in the past week, and that does not include wandering behavior. For the IDD population specifically, as I mentioned, providers increased their understanding of the progression of ADRD in the IDD population and their ability to provide dementia-capable care. This is something that we underestimated the need for, and really feel like this is an area where we made significant contribution to our region and beyond. Interviews with project partners suggested that participation in RDAD could also improve or at least maintain mobility among those they supported, and may even allow them to remain in their community longer and foster reduced hospitalizations. And finally, to make the curriculum most appropriate for the populations included in our project, our partners suggested continuing to update the content to align with the latest knowledge on ADRD, as well as simplifying some of the language and offering the curriculum in other languages. We would also like to see a version with a simplified exercise component so that there's not a need for an exercise specialist. And crucial to broader uptake and applicability to the IDD population is identifying ways to integrate RDAD into formal caregiver settings and possibly group settings. Thank you.
Thank you so much, Dr. Cherry and Dr. Barton. Appreciate your presentations. You're excellent. There are a few questions that have come in, and others continue to enter questions into the question and answer pod on the webinar platform. And while people are asking additional questions and entering those in, we'll just get started. So, Dr. Barton, there was a question that came in that was asking about the inclusion criteria of having caregivers provide a certain number of hours of care per week and having been providing that care for at least 1 year. Can you talk about the significance of those requirements?
Sure. So specifically for formal caregivers, we wanted to make sure that they, knew the person well that they were working with, and that they had, that they were spending significant time with that person. Really, the idea behind RDAD was to more target caregivers and teach them some strategies. So we wanted to make sure that those were caregivers that had a fairly significant role in their lives.
Great, thank you. Dr. Cherry, there was a question about the facilitator guide for the telenovela. I know you posted the link for the actual telenovela. Is there a facilitator guide available as well?
The facilitator guide is in development. When it is ready, it will be accessible at alzheimersla.org/professionals. We have a whole section there on facilitator replication manuals. I think it's very close to finalized. So that's where I would get it. You can also get individual, you can get hard copies of the telenovela by writing to permissions@alzla.org. And you can access the telenovela and download it for playing from our website on the link that was given earlier.
Great, thank you. Someone else asked if you are able to share about the budget and for producing the telenovela.
The budget, we initially underestimated what the cost of the telenovela would be. We did it initially with a grant of $50,000, which is very low for the development of a piece of material of this quality and scope, and then received a second grant for about the same amount to add the subtitles and to disseminate it and collect the data. Separately, for the facilitator guide, there is yet another grant from the Administration on Community Living. So just the creation and not the dissemination or evaluation, I would say that we did it on the cheap at about $70,000.
Great, thank you. And Dr. Barton, someone asked about if you could share information on your fidelity assessment process for RDAD.
Sure. So we also we did a quarterly all-hands meeting where we had representatives from each organization come, and part of each all-hands meeting was case presentations to make sure that if someone had a case they didn't quite understand maybe how RDAD was applicable or needed some additional strategies, they could present that there. And then we also had specialists who did some of the interventionist training, and she would do quarterly individual fidelity checks with each interventionist from each organization. And so she would really talk through cases with them and make sure that they were all implementing it very similarly, and make sure that she could guide them along if they were struggling at any point on any of their cases.
Great, thank you. There was another question that was asking if you can explain about targeting changing behaviors rather than establishing patterns. And what was the... Yeah.
Oh, go ahead.
Go ahead.
I was just going to say, we just wanted to make sure with our IDD population that we were targeting dementia-related behaviors, and so change over time, as opposed to maybe something that was related to their lifelong disability that was not associated with their changes in dementia symptoms.
Great, thank you. Another person asked Dr. Cherry if you are able to share the survey that you provided participants when you were evaluating the telenovela.
I believe we are able to share it, but I would have to confirm that with the evaluator from UCLA. So if someone wants to write me a follow-up email, I can find out from her if it's available.
Great, and then I'll just, I'm
dcherry@alzla.org.
I will send that out. Great. Okay. So were there any adaptations made in the telenovela to the messaging and the language? How did they ensure that it was a culturally competent telenovela? You had some specific staff involved, I think you mentioned. Can you tell us about that?
Absolutely. So we took the stories from families who were actually being helped by our social workers. And then we had staff a staff person who is a specialist, Margarita Bermudez, who is a specialist on bilingual dementia health education. And she has worked with families and done years of education of Latino families in particular. And she brought in other staff who do similar work so that they could provide feedback on the development of the script and then observe the actors and give them feedback as well to assure that A, it was culturally sensitive, and B, it actually reflected something you would recognize as dementia. Many films that use actors get a rather stunted performance, and I think they did a particularly nice job of capturing dementia without overdoing it throughout the telenovela.
Great, thank you.
You're welcome.
I did want to note to everyone who's on the line, the participants, that I went back to the slide where Dr. Cherry included the web address for accessing the telenovela, since many of you have asked for that again. It's in this blue writing toward the bottom of the slide, so you can copy it down for yourselves to access it at a later date. Okay, so a few more questions that came in. A few people, Dr. Barton, are asking if your IDD adaptation of RDAD is available online anywhere, or if it's able to be shared, so that people can take a look at it a little bit more in detail.
I do know there is an intention for it to be available online. I don't know if it is yet, but I know that you can email Dr. Vidoni, who I listed also at the end of my presentation, and he'd be happy to share anything that we're able to share at this time, as well as answer any additional questions that come up after this.
Okay, great. So in a minute, I will scroll down to that slide. We'll just give people a few more seconds to jot down the telenovela address, and then I'll move down to your contact slide. We have one more question, Dr. Barton, about the IDD population, and if you had a way to distinguish between a change that maybe was more recent, or what is it, an old behavior that was reappearing from many years ago, and if those folks with IDD had to have a formal diagnosis of dementia.
So the answer to the first one is no, not necessarily. We sort of entrusted our organizations who were enrolling participants to be able to ascertain that. We did provide a lot of training to them to be able to really understand what dementia symptoms look like versus an ongoing, behavior from long ago. So that's the answer to that first part of the question. And I'm sorry, what was the second part of the question?
The second part of the question was whether those who participated with IDZ had to have a formal diagnosis of Alzheimer's disease or dementia in order to participate.
So no, they did not. And part of that decision was because we realized a lot of our organizations really weren't screening for dementia and didn't really have a whole lot of training embedded in their program to be able to recognize that at the time. So we did have some kind of outlined strategies and language in our kind of recruitment packets that had, that it had to be a newer kind of change in behavior, and kind of gave them some guidance along with the training that we provided throughout.
Great, thank you. I just want to touch on one last question that's come up a few times. Dr. Cherry, for people having questions about permissions to share the telenovela, would you like them to email that permissions email address you mentioned earlier?
I think that the telenovela can be used by anyone. We like to know who's using it, so if you would do us the courtesy of contacting permissions@alzla.org, that would be nice for us. It's also a way to get a hard copy if we have any of those left. We had little CDs, rather DVDs with the telenovela on it. But you're not required to do that. It is up on our website and can be used.
Great, thank you. I just sent out that permissions email one more time to everyone so they can see it.
Thank you.
So I think that we have run out of time for questions. Thank you everyone for attending today, and thank you to our presenters for excellent presentations. We really appreciate your being here at the National Alzheimer's and Dementia Resource Center webinar series. And please note you can join us for our next webinar on January 28th, where we'll talk about finding the right fit, choosing dementia caregiving programs for your organization and community. I'm just going to turn it back to Steve Moore from ASA for some final remarks.
All right, thank you everyone. Thank you for joining us for today's webinar, and I also want to thank our presenters here today, Kelly and Deborah, as well as Sari, for presenting with us on this very important topic. It's time for us to wrap up, everyone. We've reached the end of our hour, unfortunately.